Hello, I'm here with Dr. Kumar from India, from the Citizen Hospital in Hyderabad. And I'd like to ask you a few questions about QFR and your experience and your vision about QFR for in the future. You're already using QFR in your CAD lab?
Yes. Do you? Yeah. Before I go on, I wish Medis all success, and I'm very happy to say that recent NIC conference, National Interventional Council, which I head now in the country, we did a live demonstration of this, and values came perfect compared with FFR. We are very excited, and we were looking for such technology where to avoid unnecessary stenting and also do the stenting for the right patient. And at the same time, what was bothering us all these years was the usage of wire. Along with it, not only the complications which a wire can produce, but the cost was prohibitively high in the country. So we were not able to use this modality of testing for all the patients in whom we were required. Now we have an exciting technology which comes just by angiographic views, taking without an extra wire and extra catheters and extra stress on patient with the financially as well as procedure damage wise. So this is another exciting technology where we find this will be very useful in day-to-day patient decision making and doing the right thing for the right patient. And the recent case which we did, the initial pre-procedure value which came was 0.78 by FFR wire, and this QFR showed 0.8. And the post-procedure both came as 1.0, which all 1,500 doctors who are attending the meeting were also excited along with me and applauded this software.
Very good to hear, thank you. What is your experience with QFR in your workflow, how to integrate it in your daily work?
We wish that it gets incorporated in the day-to-day practice in every patient evaluation. As of now, I would confess that we are not using in all the patients as a routine, but in future, suppose it proves further with outcome data and other things, it could come into the guidelines of practice. And before any patient is stented or any PCI is done, we should come out with the guidelines saying that it should be calculated, QFR should be calculated, and it has to be documented. And the value of less than 0.8, unless it is there, you should not stent. That would go a long way in taking the criticism on this profession and doing the right things for the patient, so that our unnecessary stenting could be avoided. At the same time, necessary patient gets the benefit of the stenting procedure.
Thank you. Let me think for the next question. I forgot this one. What do you think about, you're familiar with the contrast counting of QFR to find the actual blood velocity, the blood flow of the patient. Is that something you think that is necessary all the time, or is the fixed flow QFR enough for you to do your work?
Actually, we are okay even with fixed flow QFR, but unless I came to know about what are the advantages of contrast flow, which could be there in some particular subsets where of tortuosity, things like that. Otherwise, I'm okay with the baseline values too. But we would like to hear more from the research coming out where are some particular advantages by using the contrast flows.
Thank you. Do you have maybe a specific example of where QFR made a difference in your decision making? Can you describe one?
Yeah, actually that's a very good question. Recently I showed it in my presentation in the conference where QFR made a difference. When we did a left main distal with osteoarthritic disease, and we did a crossover stenting because LCX was not huge. So we had to make a decision whether to stent LCX osteum because angiographically it appeared like it is slightly pinched. So we were contemplating whether to do it or not. Then we calculated immediately FFR in that, and FFR came as QFR came as 0.95. So we left it. So that's a way we can make dramatic differences, and we were very comfortable leaving the patient. And in spite of angiographically looking little of pinched appearance in LCX, overall value came normal. So that's how we could confidently leave that patient without stenting, because obviously, as you understand, two-stent strategy, unless it is required, should not be done. Then that's how the patient, we left it with one stent crossover strategy, and patient is doing fine.
Oh, it's a very nice example. Thank you for this explanation.